Can you talk to me a little bit about the benefit of having a screw-retained prosthesis rather than a cemented restoration?
The main benefit is really, one, minimizing the iatrogenic problem that we can create by leaving cement behind. The more long-term benefit would be that of retrievability, and maybe a third benefit would be really being able to alter the prosthesis down the road and not have to cut apart and destroy some of the things that had been done previously. But the biggest one in the short run is just making sure that we don't have a cement left behind that could affect our implant outcome.
Can you explain some of the features that differentiate the CustomBase and the angle screw access from other screw-retained solutions?
Sure. So really when it comes to the Atlantis CustomBase, for me the biggest benefit is its integration with the digital world, the ability to create a core file that can be imported into lab software and directly design your restoration on the original abutment design. Helps us get better restorations. The ability to integrate that with immediate smile, with some of the Simplant things that are out there. I think just the connection to digital dentistry is the biggest advantage really of the CustomBase option specifically. The big thing on the horizon though is what you mentioned, Atlantis angled screw channel, and really would be the integration of a custom prosthetic that allows adaptation to an individual patient's anatomy, as well as correcting implant angulation and maximizing prosthetic contours and thicknesses and aesthetics. So that really is, I think, the future. And again, being able to customize it, all the better. There's very few things I feel like in dentistry that are unique. But when you can combine a customized prosthetic with angled screw channel and then add in the digital world of core files and things like that, that link to your laboratory, that is unique. That is something I don't see elsewhere in the product offerings that are available. And so those individual things, when put together, are valuable to particularly the prosthodontic world, but absolutely to the run-of-the-mill general dentistry single segment world.
And so, how does the CustomBase differ from a tie base?
Sure. So the big things is a tie base is a stock part, and stock parts versus customized parts have their strengths and weaknesses. A stock part, a tie base, generally comes in one material, titanium. CustomBase or Atlantis custom abutment can come in titanium, gold-shaded titanium, so we have some material differences or color differences. The other thing is, if you just look at the retentive feature on a tie base versus that of a custom base, there is a difference, and in some cases you need a little bit more height, a little bit more retentive resistance form for whatever restoration you're going to be attaching, and that ability to tailor it to the space that you've got is an advantage in my opinion. And again, if you look at moving your restorative margin away from the hard and soft tissue interface at the collar of an implant, we see some, I think, favorable biologic outcomes when we're not sticking that restorative margin right next to the bone. So there's some design differences to be sure, and maybe there's an advantage to simplicity in some cases, but for many cases we want that customization, we want options in materials, we want options in design.
Typically, I think a lot of people interpret the idea of an angled screw access as being something that's a rescue. You have an implant that's malpositioned. But do you think it's a product that that there's a benefit to plan for an angled screw access rather than use it as a rescue?
Absolutely. That is the thing that struck me when these things first. Yes, everybody's got a few cases where the implants are not ideally placed and you need some help. I think of the single number 8 implant. Tipping that implant a little bit more proclined to match the alveolus, to maximize native bone encompassing your implant, to not have that collar sticking up above the facial plate. all is probably a benefit, and we can then use the angled screw channel to correct our prosthetic contours, but maximize that implant position in the person's alveolus, and then secondarily maximize the ceramic and material components. If an access channel is a little bit too mesial, a little too distal, facial, whatever, we can get very thin areas, and you might be very close, you might be acceptable from a lot of different standpoints, but you want to get that just touch better. It's a way to go from good to great sometimes.
How about the fact that with CustomBase, you have two components and they have to be cemented together? Are you cementing them in your office after trying everything in, or do you get them back from the lab and have them cemented?
I personally tend to get them back as two parts because I do like to test fit these things in together. As somebody who retrieves a lot of broken abutment screws in my community, I understand that screw retained is a fantastic option, but is also one that can be fraught with difficulty if you don't have a clear path of insertion between contact points and the internal hex or internal slots of the interface or the index. And so I like to try in the abutment, try in the restoration, make sure that our path of insertion is appropriate so that we don't either orthodontically move the teeth or snap that abutment screw. And once I'm confident in those adjustments on the contacts, then cement in my laboratory and go back and insert the restoration as one piece. That way we get maybe a little bit of both worlds.
I find that the issue of the contact points is probably the most critical issue, and I don't know that you can manage those properly without trying things in separately. The downside of that is that it's a little bit of a pain in the neck to cement in the operatory, but it's worth taking that extra time to do that.
Better than digging out a broken abutment screw for the next 2 hours.
How do you plan for an angled screw access? Do you do that in your CBCT?
All implant planning in my practice starts with a CBCT, an intraoral scan, merging the files together in SimPlant, and evaluating the patient's anatomy. That way, we can use virtual wax-ups. We can merge in a second STL file and use that as a wax-up. But using that software to blend restorative contours with patient's anatomy allows us to really see what we're up against, or maybe we've actually got that rare, straightforward case. They may not exist, but in that software we can look and balance all of the factors that might be most important. Do we need to prioritize biology a little bit more? Do we have to prioritize prosthetics a little bit more? But this is where angled screw channel allows us to maybe not have to pick one or the other, but maybe do both at the same time.
I know that there isn't an actual tool for measuring, except you can measure angles, but it has to be at the top of where the screw head would be. So you've got to work from that point. Is there much of a difference of the CustomBase, the angle screw access, as compared to other products?
The angled screw options that are otherwise available have a couple of limitations. One is they either come with a stock part, which again comes with all those same things we talked about a moment ago. The other limitation is that there are ones that utilize zirconia, and if you look at how they're designed, the screw head is holding multiple stacks of things together, which from a material standpoint seems like we might be barking up the wrong tree though, and the laboratory is asked to sort of super glue this sleeve and zirconia together, which again seems to me to be asking for a bit of trouble.
Do you think that the angled screw access can translate to multiple units?
A few weeks ago I did a 4-unit restoration, number 7 to 10. The position of where the implants had to be required us to think outside the box, and we planned for an angled screw channel at both sites, and that way we can correct angle, still get the restoration we want. But yes, I not only envision it, I know that it's possible, and I know that it can be done. It does require a learning curve like anything to be able to plan this out and to use your CT to start and to move forward, but I know it's already here.